Hello everyone, my name is Rado. I did my presentation today on otitis media, so let's get started. Our agenda for today, we will meet my patient, we'll talk about his symptoms and his relevant history. We'll also discuss the physical findings, we'll talk about his diagnosis and any diagnostic test that was done, as well as his treatment plan. So let's meet our patient. WB is a 23-month-old male, presents to our ENT clinic with a chief complaint of a 2-day history of rhinorrhea, stuffiness, and 1-day history of constant tugging on his right ear with general irritability. Upon further evaluation, the patient's mother stated that the patient has had a fever of 101.5 that has been recorded on her home thermometer. The mother denies any nausea, vomiting, or diarrhea. Mother also states that he suffers from recurrent ear infections within the past year. The child has had a total of 2 episodes of OA within the last year, with the last episode being 5 months earlier than today's visit. The child has also had difficulty sleeping at night due to the pain, which wakes him up in the middle of the night. According to mom, the baby has no known allergies, has a past medical history, um, doesn't include any history of trauma or any hearing loss. He was hospitalized at 9 months of age for RSV-associated bronchiolitis, and he also had recurrent upper respiratory infections. All of his immunizations are up to date. He has no past medical surgical history. He is not on any medications. And for family history, both of his parents are alive, and he has no history of chronic illness. However, both parents are smokers. They smoke about 1 to 2 packs a day. So for his physical examination, his vitals are as follows. He does have a temperature of 100.9. His blood pressure is 101/54. Heart rate is 137. And he sat in 97% on room air. For general appearance, the patient is active, alert to his surroundings, is fussy, but easily consolable by his mother. He is well appearing and healthy looking. For clinical presentations, examination of both ears reveals significant redness and fluid in both middle ears. Further examination of the patient's breathing and other manifestations indicates an upper respiratory infection. So for supporting diagnosis, the child does have, looking at his ear, he does have this yellow tingy trailer that is coming out of his ear. Once we use the otoscope to look at his tympanic membrane, this is what we see. I placed his ear and I placed a normal tympanic membrane just to compare. So the red one is obviously the patient's, and this one is a normal tympanic membrane. So you see that his is like super red and super angry. For the diagnosis, we would diagnose otitis media based on individual symptoms, his physical findings, and the diagnosis imaging by looking at his ear with the otoscope. For his diagnostic studies, OM is diagnosed in children that have fever, ear pain. The pain is often nocturnal and severe enough to wake the child from his sleep. They would also have generalized malaise. Earache is the only symptom with sufficient positive predictive value to be useful in diagnosing acute otitis media. Generally, some of the classic findings of common signs and symptoms of OA are tugging on the ear, erythema of the tympanic membrane, earache, and fever. Examination findings include a red, bulging tympanic membrane that does not move well with pneumatic otoscopy. Redness of the tympanic membrane is an early sign of OA, but erythema alone is not diagnostic of middle ear infection, since it may be caused by inflammation of the mucosa throughout the upper respiratory tract. The motion of the tympanic membrane is proportional to the pressure applied by gently squeezing and then releasing the rubber bulb attached to the head of the otoscope. Normal mobility is apparent when positive pressure is applied and the tympanic membrane moves rapidly inwards. With the release of the bulb and the resultant negative pressure, the membrane moves outwards. This exams technique provides objective evidence of the status of the middle ear and the presence of or absence of fluids. The presence of fluid in the middle ear is determined by the use of pneumatic otoscopy, a technique that permits an assessment of the mobility of the tympanic membrane, as discussed previously. Diagnostic studies continued. The only way to determine a specific pathogen in the middle ear is to perform tympanocentesis. It is not commonly performed, and antibiotic therapy is generally used empirically. Tympanocentesis should be considered in selected patients, such as the patient who is critically ill at the onset, patients who fail to respond to therapy within 48 to 72 hours, for immunocompromised patients, for penicillin-resistant Streptococcus pneumoniae. This exam is then extremely helpful to establish a bacteriologic diagnosis for the patient. And then for treatment, after OIM episode, middle ear fluid can persist for up to several months. If hearing is normal, middle ear effusion is treated with observation. Some practitioners will treat with antibiotics. When the fluid does not resolve or recurrent episodes of suppurative OM occurs, especially if hearing loss is noted, myrectomy with PE tubes is often implemented. And I provided a picture on the side just to see what it looks like. Note that the antibiotic therapy has no important effect on hearing loss. Amoxicillin is prescribed in doses up to 80 or 90 milligram per kilogram per day for 7 to 10 days and is often the initial treatment. Amoxicillin remains the drug of choice for the treatment of acute otitis media. It will cover non-penicillin resistant Streptococcus pneumoniae and beta-lactamase negative strains of Haemophilus influenza and Moraxella. Younger children and children with underlying medical conditions, also as well as craniofacial abnormalities, chronic or recurrent otitis media, or perforation of the tympanic membrane, should be treated with a standard 10-day course of antibiotics. With appropriate antimicrobial therapy, most children with acute otitis media are significantly improved within 48 to 72 hours. If there is no improvement, the patient should be re-examined. With appropriate therapy, patient should be able to respond. But if a patient fails to respond, he may require treatment with a second-line agent for presumed beta-lactamase positive organisms. In these patients, as I stated in the other slide, that sympacenthesis to establish a bacteriological diagnosis is helpful. Optimal treatment of penicillin-resistant S. pneumonia otitis media is currently not clear and may include drugs such as IM, ceftriaxone, or oral clindamycin. Those are my references. Thank you so much for listening to my presentation. I hope you learned a lot. Thanks.